Here we discuss the management of moderate COVID-19. These are the different drug options in moderate cases. Oxygen should be treated as drug. Data extrapolated from the previous trials suggest that conservative target of 92 to 96% SpO2 preferred over more than 96% or targeting low. As per lowest FiO2 requirement to get the target SpO2, modes used in increasing order of FiO2 provided are nasal cannula, mask, non-rebreather mask, COVID awake repositioning protocol should be followed. Injection remdesivir emergency use authorization in India is used if symptoms within 10 days, total duration of 5 days infusion as shown here. The largest trial showed maximum benefit in those on supplemental oxygen. Apart from few adverse effects like nausea and bradycardia, it is well tolerated. We have to be cautious if transaminases more than 10 times elevated. Also in GFR less than 30, lyophilized form of remdesivir may be preferred over liquid form if administration is needed. In pregnancy, although contraindicated, when benefit is more, it can be given with consent as small studies have shown no harm. Steroids after recovery trial are the only drugs helpful in reducing mortality. Our national and state guidelines use a higher dose of steroids in moderate cases as above. Also in mild cases, persistent cough beyond 5 days, budesonide inhalation can produce early symptomatic relief. In anticoagulation in India, prophylactic dose once daily used in moderate cases if no bleeding risk, and low molecular weight parins preferred due to simplicity in administration. Recent trials results in USA have preferred therapeutic dosage, specifically those with raised D-dimer levels. Antibiotics in moderate cases usually not needed. However, it is at clinician's discretion as per the local antibiotic policy. Now, we are going to see drugs useful in severe COVID-19. In ventilation modes, high flow nasal cannula preferred over NIV. NIV trial can be given in conscious cases without CO2 retention before invasive ventilation. Invasive ventilation should not be delayed those not tolerating NIV. Due to different ARDS presentations in COVID, ventilatory strategies should be individualized, but lung protective ventilation should be followed to avoid the pneumomediastinum or pneumothorax. Our national and state guidelines use a higher dose of steroids in severe COVID cases as above. Unless venous thromboembolism is evident, all cases of ICU will receive prophylactic dose of anticoagulants and not therapeutic dose. Till hospitalized, it is preferred to give injectable LMWH over oral anticoagulants. Now, cases which require oral anticoagulants on recovery, we suggest using IMPROVE D-dimer risk score calculator. Injection tocilizumab, an IL-6 receptor antibody, required less frequently in Omicron wave. It had shown modest recovery in ICU cases. However, the exact subset of cases who will exactly benefit is still not known. Regarding tocilizumab, used in severe COVID-19, indicated in rapidly clinical deterioration with worsening hypoxia, and it should be used with steroids in 4 to 6 mg per kg infusion. Here are some of the contraindications. The largest study used cutoff of CRP 75 mg per liter. It is suggested to get blood culture sensitivity before administering empirical antibiotics in sepsis cases. However, it is at clinicians' discretion as per local antibiotic policy. We are going to see investigations in COVID with respect to severity and prognosis. No investigations is specific for COVID. Also, clinical severity determines the treatment changes rather than investigations. Only exception to this is CRP for tocilizumab. In those hospitalized and whose workup had shown higher neutrophil to lymphocyte ratio or reduced absolute lymphocyte count or thrombocytopenia, latter in the disease had high chances of progression to severe COVID. Worst outcomes were also seen in those with deranged organ functions and electrolyte deficiencies. Although hypoglycemia and persistent hyperglycemia are already risk factors, a higher fasting glucose in itself is an independent risk factor of severity. LDH above normal is a marker of severity. However, it is present in all living cells, and during sample collection, hemolysis can occur, elevating LDH. Ferritin above this level is said to be a marker of inflammation. However, being an acute phase reactant, values to be clinically correlated. Prolactin is elevated in severe COVID and does not necessarily mean sepsis. However, higher values may suggest a secondary bacterial infection. However, no cutoffs are specific. A higher CRP is associated with worse prognosis. Due to its short half-life, it has advantage and can be repeated after 2 to 3 days. A higher D-dimer is associated with high severity. The cutoff values for venous thromboembolism are not defined and should be clinically correlated. Cardiac markers are also elevated in severe COVID due to inflammation and does not mean ischemia every time. Chest radiographs with more zones involved is associated with high severity. A CT chest with higher severity score more than 15/25 has a severe COVID-19.